what I would like to focus is that this baby, unlike other babies, we will not be drying this little one. This little one is totally covered with warm amniotic fluid, and this warm amniotic fluid is going to be the insulator, and it's going to prevent transepidermal water losses. So as soon as the baby is delivered, the baby will be accommodated within this polyethylene bag. Also, please note that the temperature is preserved by putting off the ACs and the fans. Everything is off. So we are all set as far as the thermal control is concerned. Next, please note that we have a Massimo pulse ox, which will read the target saturations, and this pulse ox will be put on as soon as we get the baby into the bag. Next, after the oxygen, we go on to the ventilation. Naresh, have you arranged everything for ventilating this baby if the need arises?
Yes, ma'am. So, since we are receiving a preterm baby, so I would like to emphasize that we should be ready with a bamboo bag with a preterm size mask, and all this has been pre-checked and make sure it's in a working condition. Apart from the bag and the preterm mask, we have a laryngoscope with a size 00 blade, which is in a good working condition. And apart from that, we have a VT tube, preterm size 2.5. VT tube is kept ready, and things to fix plaster and things to fix the ET tube. So apart from that, we also have to set up the T-piece resuscitator. So in such a way that we have to make sure that it has to be, in case baby requires non-invasive ventilation, just CPAP, or in case baby requires invasive ventilation, we might have to require the PIP as well. So this has to be set with the PIP measure. The PIP valve is here, so we need to set at minimum of 20. So I'm adjusting this to achieve the pressure of 20.
Yeah, please note that this T-piece resuscitator takes at least about 30 to 40 seconds to be set up. So we cannot wait for the baby to arrive before setting this up. So Naresh has got both the CPAP as well as the PIP and the EEP ready before we get this baby onto the warmer.
So this is the PEEP valve, so through which we have set the PEEP at 5 mm, and also we can see there is a FiO2 dial here, wherein the T-piece has already been connected to the air oxygen blender, and we can set up the FiO2 between 25 to 30% since it's a preterm resuscitation.
Yeah, the beauty of this T-piece is that it comes with a blender, so we prevent hyperoxia in the preterm baby by just starting with about, say, 25 to 30% oxygen. So depending on our target sats, we will be dialing the FiO2 either up or down. And Vinod here has got the umbilical venous catheter tray ready. So this is a central venous set that is kept ready for the baby. In addition to this, we already have prepared 1 in 10,000 adrenaline and also normal saline. Everything is kept ready for the baby, including the medication. So we are all set to go. We have the thermal apparatus absolutely ready. We have equipment to monitor oxygenation. We have equipment to ventilate the baby either on a CPAP or on an invasive ventilation. And if the baby requires, we are ready with the medication. So I think we are all set. We can receive the VIP. Yes, the gynecologist has delivered the baby. Here comes the little one. She is really tiny.
7:25.
Time delivery 7:25. As you can see, we are not drying the baby. We are immediately getting her into this Ziploc bag or the polyethylene bag. The baby is definitely breathing on her own, and we need to get a pulse ox. As you can see, Manu is very quickly getting her little hand out of this polyethylene bag, and we are hooking up the pulse ox to her right upper limb. The right upper limb is preferred because this is a preductal SATS. Naresh, I can see that the baby is breathing, but she is definitely recessing quite a bit, Naresh. So I think this baby will require some kind of the support. I think I would like you to get the CPAP on, please.
Yes.
Before we get the CPAP on, I think this is the steroid pad which which Manu has kept ready. Please wipe the face, Manu. Please note that we have not wiped the rest of the body. Only the face has to be wiped before Naresh puts on the CPAP mask.
Apply the mask by cupping onto the chin first, then covering the mouth and nose, and achieving a tight seal so that the PEEP achieved here should be at least 5. So
yes,
we are achieving a CPAP of 5.
Yes.
And we can see
the saturations are about 78, 80. So we definitely don't need extra oxygen here. I think I'll dial the oxygen down. Let's start with room air because our 1 minute sat is already 79%. So we definitely do not require extra oxygen. So she is now in room air. The baby appears quite pink. She still has a little bit of recession. CPAP always takes a while for the FRC to be gathered. So I think we'll not panic. We'll just wait for some time. Just hold the face seal effectively so that we are having a continuous CPAP of 5. Are we, Naresh? We are having a CPAP of 5? Good. I don't think we need to ventilate this little one because her respiratory efforts are pretty good. And now we even see that her grunting is far less. So she will not require advanced forms of ventilation or medication. I have checked, let me check her heart rate. Yes, 6 seconds, 120. Heart rate is 120. So I think she is stabilized enough. We'll just wait for a couple of minutes, then probably shift this to a humidified, get this down, shift her onto a humidified incubator, and probably transfer her to NICU for further management. I think we are done with the preterm resuscitation program.
Madam,
can you hear?
Yeah, madam. Madam, you can go for the PPT of the, what is it, resuscitation you have showed for the preterm. You can go for the, what is it, ethics.
You want me to go for the ethics?
Or you want to go for any other things, you can go, madam. Special consideration, special situations, whichever you want. It's up to you.
Okay. No, whatever you want, depending on the time, tell me what you want me to do and I shall do that.
Madam. No, see, we have told up to 8 o'clock. You can go up to 8:15. 8 o'clock, if you'll stop 30 minutes, there are 18 questions people have asked. So another quick, I will ask the questions later after your class is over.
Okay. After we finish the video on the preterm resuscitation, I'd like to go for special scenarios where we may have some problems post resuscitation. So sometimes I must tell you, after we have resuscitated a baby, say we have established respirations. But however, this baby can have secondary apnea. That means the baby can remain cyanotic, he can remain apneic, or he may remain bradycardic. So there are certain situations where the baby initially seems to improve, but later suddenly plummets and we have a lot of problems. So there are 3 types of problems that can happen. Number 1, we could have problems with ventilation. That means where positive pressure ventilation fails to achieve chest movements. The second situation that can happen is you may have a baby who is persistently cyanotic and whose saturations just don't pick up despite supplemental oxygen, or who may continue to have desaturations with brady despite good chest movements. The third possibility is when we have a baby who unfortunately fails to establish spontaneous respirations. So when we are in a fix, first we need to find out whether it's the first group, whether it is failure of positive pressure ventilation. Number 2, whether it is persistent hypoxia desaturation cyanosis. Number 3, whether it is failure of spontaneous respirations to happen. Let's see the first scenario. The first scenario is when positive pressure ventilation fails to result in adequate ventilation of the lungs. So the most important thing that we need to concentrate is on mechanical blockage of the airway. It could be a meconium or a mucus plug. One of the indications for endotracheal suction, all of us have emphasized that a depressed baby with meconium does not need endotracheal suction. That is very true, except in the instance when meconium causes a blockage and you're unable to achieve chest movements. So in such an instance, you may have to do endotracheal suction and then continue with positive pressure ventilation. There are some anomalies that we encounter in the NICU in the form of choanal atresia or a Pierre-Robin malformation. In these malformations, the upper airway is totally blocked, and how do we deal with such problems? Number one, let's have this scenario of choanal atresia. Please remember, the choana are nothing but the posterior nerves that communicate with the pharynx and the larynx. So if we have a unilateral choanal atresia, it is not much of a problem. The baby always manages with the other choana. Only when it's a bilateral choanal atresia, we all know that babies are obligatory nose breathers. They get into very severe distress, and paradoxically, this baby will appear pink when he starts crying and when he opens his mouth. So in this situation, we insert an oral airway. We always have an airway ready in the NICU for any such emergencies. This is the oral airway. This comes in various sizes, size 0, size 1, depending on the size of the baby. Please remember, this is a very essential component of our crash cart. So when we are encountered with a baby with severe anomalies, this is a major airway management. The second possibility is that your baby could have a Pierre-Robin syndrome, where there is a severe glossoptosis. That means it's a posteriorly placed tongue which falls upon the laryngeal opening. This is also managed by prone positioning and a nasopharyngeal tube. That means you pull the tongue forward by putting the baby in the prone position and put in a nasopharyngeal tube. Normally we use the ET tube. The ET tube is used in order to secure it behind the tongue, the posteriorly placed tongue, so that acts as a oral conduit, and that establishes respiration in these babies. Please remember, these are all delivery room emergencies, and we really need to be prepared with this. Nasopharyngeal airway is not a problem because we use the ET tube as the nasopharyngeal tube. It's the most important thing is you need to have this airway, nasopharyngeal tube, in order to salvage babies with choanal atresia. The third possibility is we have dealt with upper airway problems. Now the upper airway problems are choanal atresia and Pierre-Robin. We can have impaired lung function. So many a time while we are resuscitating, especially with an ambu bag, a self-inflating bag, we do not know what pressures we are ventilating this baby on. In our anxiety, we sometimes go up to pressures of 28, 30, 35, God knows what, and this can result in a pneumothorax. So always suspect common things first. If a baby temporarily seems to improve with resuscitation but suddenly becomes bradycardic, cyanotic, please suspect pneumothorax. Tension pneumothorax in the delivery room can be pretty disastrous. You can see this X-ray. This is not the heart shadow, that is a collapsed right lung. You can see that the entire mediastinum is shifted to the left. So this is what is called a tension pneumothorax. It's a massive right-sided pneumothorax. Unless you aspirate this in the delivery room, you can as well forget the baby. So what do? We put in a scalp vein or a size 18 cannula. Please remember the baby is supine, so we'll have to put in an anterior tube. We put in a size 18 cannula, connect it to a three-way and aspirate the air. If necessary, we may also have to put in a chest tube in the delivery room before we shift him to the NICU. Shifting this sick baby can be very disastrous. So all this management has to be done in the NICU. The picture that you're seeing on top is a cold light source, which all of us commonly have in the delivery room. This cold light source just trans-illuminates the chest when there is a lot of air. But remember, this cold light source is not a mode of diagnosis in a term baby. It can be done only in preterm, low birth weight babies. The second thing that you can probably have is a congenital pleural effusion. So the commonest reason why babies have pleural effusion is a hydrops fetalis. But very rarely we have had babies with chylothorax who have presented with pleural effusion. The more common thing is a congenital diaphragmatic hernia. These days, diaphragmatic hernia diagnosis in the delivery room is rather rare because majority of them get picked up on the antenatal ultrasound scan. The other very disastrous thing that can happen in the delivery room is a severe pulmonary hypoplasia. For example, you have a baby with chronic oligohydramnios. You're just not able to ventilate this baby because of extremely stiff lungs. And extremely premature babies less than 24, 23 weeks also have very stiff lungs because of absence of development of alveoli. Of all these possibilities, it's the pulmonary hypoplasia which perhaps has the worst prognosis. Next, of course, to extreme preterm babies. So when you fail to ventilate, please suspect upper airway anomalies as well as lung problems, the commonest of which are pneumothorax, diaphragmatic hernia, etc. Now let's go to the next scenario. The next scenario will be, what happens if you've got your ET tube in situ, you're delivering 100% oxygen, you have stabilized the baby with 100% oxygen and chest compression, but you have a baby who's deeply cyanotic, whose saturations are probably 40s and 50s. So in this scenario, I'll give you a very important clue. Please look at the heart rate. If the heart rate is low with poor saturations, it's 100% failure of ventilation. So if a baby has desaturation with severe bradycardia, always the problem is with ventilation. Your tube is probably not in the right place, or you may be having a massive pneumothorax, which is causing this. So think of common things first. Always rule out a ventilation problem when you have a baby with desaturation and brady. On the other hand, if you have a baby with cyanosis but with a normal heart rate, it is very likely to be one of the cyanotic heart diseases. Babies with cyanotic heart disease appear quite happy. They're looking, they're looking quite active. Their perfusion is okay. It's only that they are deeply cyanotic. Please remember, heart rate is the clue to the difference between these two disorders. Third scenario, which is a very pathetic scenario, is you have ventilated the baby. The baby looks good, heart rate is good, perfusion is good, air entry is fine. But you are not able to extubate this little one because he just does not breathe. Failure to extubate the baby. So what could it be? There are several possibilities. Number one, if this baby has had a prolonged in utero asphyxia, this failure to breathe could be secondary to stage 3 hypoxic ischemic encephalopathy. This happens in babies who have been severely compromised in utero, but you will have clear-cut history of a prolonged labor, difficult labor, meconium stained liquor, things like that. And when you do a blood gas, the cord blood gas is usually done in our setup in such sick babies. The cord blood gas shows a very bad pH, maybe 6.8, 6.9. So the baby fails to establish spontaneous respiration. The second possibility is structural abnormalities of the brain where, for example, you must have heard of Ondine's curse and things like that. But as I said, please think of common things first. The commonest situation where this happened is a drug-depressed baby. If you have had a mother who's received morphine or pethidine in the last 4 hours because of her PIH status, but more commonly we have found drug depression secondary to maternal magnesium sulfate use. Mothers are given MagSulf, especially in preterm labor, in order to improve the neurodevelopmental outcome. But sometimes this magnesium sulfate has a side effect. It causes severe respiratory depression in the baby. So if you have a history of drug intake, do not panic. If it's a narcotic analgesic, you can give naloxone. But if it's magnesium sulfate, all you need to do is ventilate this baby, maybe for a period of 12 to 24 hours. Continue, transfer the baby to the NICU, continue ventilation. By about 24 hours, this baby will start breathing and ultimately you can extubate. Such drug-depressed babies generally have a very good prognosis provided they are managed well in the delivery room. Whereas babies with stage 3 HIE, babies with intracranial abnormalities, definitely do not have such a good prognosis. So history, clinical examination will tell you why exactly your resuscitation is not succeeding. So when you choose to give naloxone as an antidote to morphine or pethidine, please remember naloxone is given IV and the recommended dose is 0.1 milligram per kilo. Gone are the days when we gave naloxone by the ET method or the ET route. IV route is the preferred choice. So these have been quite sick babies who have required extensive resuscitation. So you definitely cannot leave this baby by the mother's side. These babies are shifted to the NICU for post-resuscitation care or ongoing care. This has already been stressed by Dr. Sahana and Dr. Chandrakala. I won't go much into those details. Needless to say that they will have the full complement of monitoring done, temperatures, heart rate, blood pressure, blood gases, and lab-wise fluid electrolytes, sugars. And the most important thing is we'll have to look for possible organ system injury, especially in HIs. You look for renal failure, you look for evidence of IVH, you look for cerebral edema, cardiac compromise in the form of poor ejection fractions, necrotizing enterocolitis. These are the possible complications of a baby who has had severe perinatal asphyxia and prolonged resuscitation. So post-resuscitation care of these babies becomes very, very important. And the resuscitation outside the delivery room. Supposing you have a baby in the NICU who suddenly crashes. You have a premature baby who's about 15 days or 16 days old. Suddenly he develops a major apnea or a massive apnea with bradycardia. The resuscitation principles are the same. Number one is always airway. Please remember the difference between a neonate and an adult. In an adult, if somebody crashes, the first thing they do is chest compression because cardiac compromise is very, very common in adults. In a neonate, the cardiac comes always second. It's always the airway first. So you secure the airway, you ventilate the baby, and go as per the protocol of the NRP. 30 seconds of effective ventilation, your heart rate remains low, add chest compression. Then you know when to add medication. After 60 seconds of effective PPV combined with CC, give medications. So same resuscitation principles apply to a baby in the NICU or a baby who may be received in the casualty with a sudden arrest or a major apnea. Outside the NICU, if you are not able to get a vascular access, the second possibility is that you can probably try intraosseous access, but nothing like getting a venous access. Intraosseous is not as good as IV, but in the absence of IV access, that would be probably the second choice. So with this, I think we have dealt with all the scenarios. The first scenario of failure to ventilate, the second scenario of a cyanosed baby, the third scenario, a baby who fails to establish ventilation. But please remember, stabilization of these sick babies must be done in the delivery room, including draining of a pneumothorax, including ventilation, resuscitation, everything is done. The baby is stabilized and then only shifted to the NICU. So even in the delivery room, you need to have equipment to drain pneumothorax, to drain a pleural effusion. All these must be ready and should be used as early as possible, ASAP, to get a good result. I think with this, we have covered the delivery room emergencies.
Madam, you can go for the ethical things quickly, madam.
Okay. I think I'll take another 10 minutes. That's it. Janaka, is it okay?
Yes, madam, go ahead.
Okay. Next, we come to the last part of neonatal resuscitation, that is ethics. So I would just like to tell you that there are 4 basic principles of ethics. The first one is autonomy. By autonomy, it means that a person should be able to make a decision for himself. This applies to adults, but unfortunately, a neonate is not able to make a decision for himself. So it's always the parents who are surrogate decision makers for the neonate. So you should remember that the decision of the parents is extremely vital in any neonatal resuscitation scenario. Number 2, beneficence. That means as doctors, we all have taken up Hippocrates' oath. So our idea always should be to benefit the baby as much as possible. Non-maleficence and justice. What I thought was, instead of giving a lecture on this, I thought I will present to you 3 cases from my own unit where we had problems, and I'll show you how these problems were solved. So doing it on a case based is always very interesting. So the first case, let me tell you, was that of an extreme preterm. We had a primey, 35 years old, and this was an IVF pregnancy. So you can imagine that this was a very, very precious pregnancy. This IVF was successful only after the 3rd attempt. So the parents had gone through a lot of mental, financial, etc., all kinds of stress. But the bad news was this poor lady went into spontaneous preterm labor at 23 weeks of gestation. And an ultrasound done a week ago had shown an estimated fetal weight of only 500 grams. So she was admitted to the delivery room in the morning. So urgent counseling was very, very important in this scenario. What I must emphasize to you here is we always do a combined obstetric and neonatal counseling. That means the senior neonatologist and the senior obstetrician sit with the parents together and counsel them together. But let me also let you into another secret. The obstetrician and the neonatologist, we first speak to each other so that we are on the same page. The obstetrician cannot give a very hunky-dory diagnosis and the neonatologist says the scenario is hopeless. So it's very, very important even legally that both of us say the same thing and that we are on the same page. So we call the parents and counsel both, and during the counseling session, both of us are present, the obstetrician and the neonatologist. So what are the points to discuss? So here, honesty plays a very, very important role. This is what I meant by saying justice. We not only treat babies, we also have to be very, very honest about our outcomes and about what is expected of the baby. So what did we tell them? We tell them the statistics of our center. Please note the last sentence. Regional statistics are important. I cannot quote the survival figures in Japan. In Japan, at 23 weeks, the survival is close to 70%. In our unit, honestly, we do not treat babies at 23 weeks. Our mortality at 23 weeks is close to 80 to 90%. So I will be very honest and say that the mortality is going to be very high. And in addition to mortality, morbidities, especially in terms of severe retinopathy of prematurity. Your baby can have blindness, baby can have severe deafness, and most important, large IVH is a very, very likely possibility. And because of this large IVH, the long-term neuro outcome is definitely not going to be good. So both in terms of mortality and morbidity, we are not at all giving you a rosy picture. The other honest thing that we tell these parents is, in our unit, we do not cater to babies at 23 weeks, but we can inquire and see if other units do take these 23 weekers, and it is your choice. We are very happy to transfer you to units that take care of these babies. This is very, very important, especially when you have time to do this. Of course, if the lady is in far advanced labor, that cannot be done. So this is a very honest counseling that goes on much before the delivery of the baby. The other important thing I want to let you into is counseling should also involve the elders in the family. As you all know, we have excellent social support in our society. So it would be good to invite the parents of both the girl and the boy into the counseling session, because these two youngsters are under great stress. They may not, many a time, they do not understand what you're saying. It takes several hours to sink into the cerebrum what counseling has been done. So if they have some kind of a social support, it always helps them to make a reasonable decision. The other thing is we are looking at our own time also. You do a half an hour counseling and then you go out into the corridor, some guy comes and says, oh, doctor, what is it? And you have to repeat the whole thing over and over again. So it's always good to get the close family members into the counseling session. The other very important thing is please communicate with empathy. Do not be businesslike and do not be rude. Put yourself in their shoes. Counseling with empathy or communication with empathy is very, very important. So we let them make the decision. If Always remember it's the parents who take the call. We have presented to them what we need to tell them. But if they say, in spite of all this, no, doctor, you do everything, definitely we are going to do a full resuscitation. We are going to ventilate, surfactant, everything will be done. But if after careful thought they decide not to resuscitate, so these are the only two possibilities, isn't it? Either you go full on or you don't resuscitate. Whatever is decided, documentation is extremely important. Documentation by both the parents in the file is very, very important. Because nobody can say later that, we never meant this. I never meant to say this. You made me write this, things like that. Documentation in their own handwriting is very, very important. So what do we do? Once this little one is delivered, no active resuscitation will be done as per the request of the parents. We give the baby what is called compassionate care. This is these days called redirection of care. That means we do not ventilate this baby. This baby will be kept very comfortable. We take care of thermal comfort. We keep the baby under the warmer next to the mother with a heated mattress. The mother is allowed to cuddle the baby, spend some time with the baby, and we give them privacy so that the family spend some time with this little one for the short amount of time that he is going to survive. But what is very, very important in the counseling is, please emphasize, they should not reverse their decision after a few hours of the baby. What happens is they see the baby breathing at about half an hour, 45 minutes, then everybody dash and say, doctor, do everything. So in this half an hour, enough damage has been done. So please tell the parents, once they have made a decision, they should stick to their decision. They should not reverse their decision, because that is going to result in worse outcomes, because this little one would have become hypoxic, hypoglycemic, hypotensive, everything. So the scenario is much worse than if you had started resuscitation at birth. So this is how we counseled. So what were the lessons that we learned? Number one, honest opinion on the outcome. This is very, very important. And this is regional. This is based on your own center. You cannot quote from books. You need to have your own statistics and you need to be honest about it. Autonomy. We have given full permission to the parents to decide what they want to do for the baby. Please remember, as a neonatologist, you have no right to impose your decisions on the baby. Ultimately, it's the parents who take the call. And through this decision, through this counseling, empathy and support to the family is very, very important. These things, please believe me, takes a lot of your time, and especially happen on Sundays and holidays. So I think you should not worry about it. These are the few lessons that you learn from counseling these. It is these difficult babies who can also land you in court. Legal problems always happen with these controversial things. So you need to be very careful in wording your sentences properly, in getting the documentation, and in being very courteous to parents. As junior postgraduates and young postgraduates, one very important thing you all should learn is to communicate properly. Communication is very, very effective, which unfortunately is not taught in medical schools. But these days, all of us emphasize on good counseling and good communication. Let's go to the second case. This was again a very confusing baby. We had about 3 years ago a 29-year-old who came to us in advanced labor. The gestation was not known. This lady had irregular cycles. But what she told us was, "Arting lagide." So artinglo means it's about 24, 25 weeks. And she had got a scan done about 2 weeks ago, which showed a 650 grammer severe IUGR baby. And this family had attempted to terminate this pregnancy, but I do not know, it was a failed termination. And she was rushed into the delivery room in very, very advanced labor. The parents were awfully confused. They didn't know what to do. When we asked them, when we spoke to them during counseling, we had a very, very brief counseling with them because we could meet only the father because the mother was in advanced labor. We had very little time to counsel the dad. The dad said, "Just leave me alone. I'm too stressed. I don't know what to do." And they had no family support. parents, I believe, were in some other place, who had no family support. He said, you do what you wish. I do not know what I should do. So next, what happened? Please remember, gestation and the estimated weight are not at all accurate in the second trimester. The gestation that you thought was 24 could turn out to be 26 or 27. Even weight can differ to an extent of 100 to 200 grams. The most accurate estimate of gestation and weight are in the first trimester. It becomes less and less accurate as you go on to the second trimester and the third trimester. So please do not stick to the antenatal scans. Seeing is believing. So what did we tell the parents? We told the father, do not panic. We will see the baby. We will assess the baby. Then we shall take a decision. But please remember what we discussed. Our team, what we discussed was the default decision should always be to resuscitate. As neonatologists and doctors, our aim is always to save babies. So forget the father and mother, poor things, they were not able to make a decision. We were all set to receive this baby and resuscitate this baby full on. So this also, what happens is, gives the parents some time to decide. Don't sit on his head and say, what should I do? What should I do? Just leave him alone. See how things turn out. See what a beautiful thing that happened. We got a little baby girl who weighed only 780 grams. She was totally vigorous at birth. She came screaming and kicking, and she had very good APGAR scores. We did not have to do anything. We just admired the beautiful little girl, and we did a Bellard. She was 27 weeks of gestation, severe IUCR. And to our happiness, she had a very uneventful NICU course. She was with us for about 8 to 10 weeks. She even now comes to my OPD. She's 3 years old. She's neurologically totally normal. A little low birth weight. She only weighs about 8.5 kilos at 3 years. But a neurologically totally normal baby. So this turned out to be a very, very happy story for the parents. So do not panic. Do not make premature decisions. See the baby, see how things turn out, then make decisions. So this story had a very happy ending. The last case, we had a 37-year-old lady who had prolonged labor, thick meconium stained liquor. She had gone to 2 to 3 hospitals which would not handle her. They said, you are very sick and we are not able to hear the heart rate, etc. So please go to a major hospital. And she came to our hospital. When the obstetrician assessed her in the triage, they found severe fetal bradycardia on admission. So immediately in the next 10-15 minutes, an emergency LSCS was performed. To their horror, the gynecologists found ruptured uterus. The baby was in the peritoneal cavity with meconium smeared all over the body. When we attended the delivery, the baby had no breathing, no heart rate. It was a 0 APGAR at birth. Of course, we did extensive resuscitation, bag and mask, chest compression, UVC, medication, etc. All this took about 20 to 30 minutes, but there was not an iota of improvement. The heart rate did not appear. So all of us had a uniform counseling. We wondered whether we could do anything else. But before we stopped resuscitation, the important thing is we called the family, we called the father rather, we called him into the resuscitation room and showed him that everything has been done, but your baby is not breathing, baby's heart rate has not come up. Father said, no, please continue to do your best, because he was in a state of shock. He didn't want to accept it. They always go through this phase of denial. We said, okay, shifted the baby to the NICU and just put him on the ventilator just so that we give the father time to digest what has happened. Ultimately, the parents agreed that it was futile to continue care, so the baby was disconnected and given comfort care. So here in the counseling, what happened? We gave him very clear and honest information. We told him that we could not resuscitate the baby, but assured him that the best efforts were made. Please remember, blame game is to be avoided. You can't tell them, oh, you should have come to our hospital first. Why did you go to 3 hospitals? You wasted time, You made your own mistakes. So please avoid this blame game. And the very important thing is, please avoid unpleasant phrases. When you speak to parents, do not say things like, oh, it all happened for the best. Don't worry. You can have more babies, After all, it was only a newborn baby. Anyway, you're not attached to the baby. Forget it. I think all these kind of unpleasant phrases should never ever be mentioned. Please express empathy. Say, I can understand what you're feeling. But unfortunately, in spite of our best efforts, this is what has happened. These unpleasant phrases should definitely be avoided totally. So I think we come to the end of this. I just want to give you a few key messages before we leave. Always remember that parents are the surrogate decision makers. You cannot surpass parents and give your own decision. Your job is to give accurate information, be honest about the prognosis, give accurate information to them. They are the ones who will decide for the baby. Parental desires must always be respected and always involve the close family members. And that is more rewarding. It also gives a lot of support to the parents to make a decision. Last but not the least, never forget to document minute by minute from the first minute of resuscitation. Never ever forget to document. Thank you very much.
Thank you, madam. Thank you. Director, sir.
Dr. Prashant.
Ye-
Yeah, very
yes, sir,
nice talk. Dr. Janaki madam, as usual, excellent, very good, crisp, really good talk. But so just I thought I'll start with Dr. Janaki. Madam,
Yes, Janaki.
I know that it is not a question of NRP. Just do you keep any camera or counseling inside the resuscitation room, and what is it, audio visual recording in the resuscitation room? Have you kept it ethically to safeguard yourself or the hospital? Anything, is there any rule, or is it better? What is your impression? It's out of NRP, sorry, because I
Yes,
have to
yes.
go 19 questions of NRP. Okay.
Okay. Very good question, Dinakar. What we do is we do a video recording of the counseling session that happens prior to resuscitation. But in the resuscitation room, if the father wants to come, many fathers are allowed to witness the deliveries and to be with their wives. So if the father does wish to come in, he can come in and stay during our resuscitation. Video recording of the resuscitation is not done in the delivery room because mothers, for personal reasons, mothers definitely don't like the deliveries being video recorded. And invariably, the warmer is in one corner of the delivery room. It's not in a separate room. So part of the delivery room also gets recorded. So in order to safeguard the privacy of mothers, video recording is not done in the DR.
Suppose if it is a separate resuscitation room.
No, in our hospital, we do not have a separate resuscitation
No,
room. The
I'm just
labor rooms are
asking.
very big. Perhaps it may be allowed if the resuscitation room is totally separate from the mothers. Maybe we could do a video recording. That shouldn't be a problem. But in my hospital at the moment, we are not doing it because the resuscitation is done in one corner of the delivery room. Delivery rooms are pretty huge and we have enough space for the baby and the mother.
Yeah, madam, I'll start with you only.
Okay.
It is a question asked from our esteemed delegate. How to diagnose pulmonary hypoplasia in labor room without history of oligohydramnias or rib problems on physical examination in the labor room?
Yeah, good question. One clue that I can give you is these babies chest movement will never happen with bag and mask ventilation. You will fail to get good chest movements on bag and mask because the lungs are really stiff. So you need to intubate these babies. Even after you intubate, you find that you need pressures of 35, 40 to inflate the lungs of these babies. The lungs really feel very stiff. So this is the first clue to say that this is a hypoplastic lung. The second thing that we do is we also take X-ray, a portable X-ray in the resuscitation room, and the portable X-ray will show very small volume lungs. The lung volume is hardly at fifth space, fourth space. So this low volume is very suggestive of a hypoplastic lung. So number one is requiring very high pressures. Number two, corroborate with a portable X-ray in the delivery room. These two clinch the diagnosis even in the absence of history of go-ahead randomness.
Yeah, madam, you have another questions. Please hold on. You have another two questions, and one more is popping up for Dr. Janaki. Dr. Sahana, madam, are you here?
Hello.
Madam,
Sure. Yeah, tell me.
Meek
Okay.
question.
Okay.
Okay, for you. It's a beautiful question, but the
Okay.
thing is, you have to digest because the people are asking. So it's my duty to ask you, please.
Okay. Okay.
Madam,
If I will
have.
answer, otherwise you please answer.
నాకు తెలియలేదు. You are the master.
Yeah,
Okay.
madam is here, mentor to everybody.
So Dr. Janaki is there and Dr.
Yeah.
Chandrakala is there, Prashant is there, and many
Yeah.
people are also there.
Okay.
We have Neopuff
Okay.
with us, and even central oxygen is there with us.
Okay.
So do you think, according to the protocol, ambu bagging is necessary? And because we have a Neopuff and oxygen, in that Neopuff, already oxygen blender is there. What doctor, that's what when you are asking, they have asked. So do you think ambu bagging is necessary? Because cleaning, source of infection, we have
No.
to work it, we have to send it for the ETO sterilization or autoclave. Chances of missing many things are there. What is your impression?
See, in a place, in a corporate setting, it is okay or not. In a corporate setting, but resource limited places, it is not available in all the places. One, your T-piece resuscitator. It is ideal to have a T-piece resuscitator in a delivery room, of course. If you have, it is well and good, you use the T-piece resuscitator, or else our friendly ambu bag is good enough.
So friendly ambu bagging is good. Okay, madam. Very happy. And one more thing.
Dr. Janaka, I want to add.
Yeah,
Dr.
please,
Janaka, I want to add. Yes, it is always important to have a backup of self-inflating bag in any unit.
It is.
It is
a must.
important. It is important to have a backup. Yes.
Please, madam, please.
See, the main advantage of a self-inflating bag I have personally found is that you can feel the lung. You can feel whether the lung is able to inflate, whether it's an inflatable lung or a stiff lung. This you will never be able to do with a T-piece. So I personally find that I always start with an ambu bag, feel the lung, then I go on to a T-piece. When I feel the lung, if I find that the lung is very stiff, I'll set higher pressures on the T-piece. If I find that I'm able to inflate with very low pressures, then I will set low pressures on the T-piece. So the self-inflating bag gives me a very good idea what my lung is. Without looking at the X-ray, you can know whether it's an inflatable lung or a stiff lung. That's the most important advantage of a self-inflating bag, the feel of the lung.
Very good. Excellent answer. And one more thing. Dr. Sahan, and for it's everybody, please, everybody can answer because it's for everybody. Madam, you have told Dr. It's for the Sahana. Room temperature 26 to 28. Even Dr. She's added one more time for the, even when Dr. Janaki was asking, my room temperature is 26. Now it is raining because of depression. Bangalore temperature is 26. So it is God given AC. But in our area, it is 32, 34. So but I don't have, it is a resourceful setting. Why 26, 28? Because we are following, is it American? Let it be our temperature be 32, 34. Why to follow that 26? Is there anything for everybody? First Sahana, then everybody.
It should not be less than 25 degree. It can be between, ideal is between 26 to 28 degrees. It can be more than that also.
Yeah.
So that's all. All three people answer is same.
Yes.
Dinakar, why we stress on 26 to 28 is majority of the delivery rooms and the NICUs are air conditioned. So for air conditioned rooms, it is stressed at 26 to 27. But if you do not have an air conditioned NICU, you rely on room temperature. And most of the times in Bangalore, the room temperature, even in the hottest of summers, is around 36, 37, which should be fine for the baby. But what I would like to emphasize is in very hot regions, when the extraneous temperature is 42, 43, it may turn out quite deleterious for the baby. So in such instances, it's always good to get the room temperature down because hyperthermia is as dangerous as hypothermia in a neonate. This 26 to 27 came about mainly because of air conditioning in NICUs and in the delivery room and the operating theaters.
Yeah, it's very nice. We have currently having the electrical suction. Central vacuum suction is also there with us. Food suction is also there with us. Still, we should keep what is a Deely's catheter and bulb. Is it necessary, Dr. Sahana, and for all the things, all the other speakers? Please.
If you have the
Uh,
wall mounted suction, it is okay. Otherwise, this even in a PHCs, no, many a times cleaning is not done. So this is a use and throw, disposable one. You can just use it and throw it. So many a times it was available even with the kit where we used to have a blade and a cord clamp. That used to be in a government supply.
Dinakar, can I make a correction?
Madam, all the questions is for 3 one by one, please.
See, Deely's suction catheter is banned. It should not be used at all because it's very difficult to clean it. The best thing would be in the peripheral setup, as Dr. Sahana said, oral mucus sucker is the best. I'll tell you the advantage. Excess pressures cannot be exerted with an oral mucus sucker. Whereas your wall mounted suction, you should be very, very careful to keep the suction pressures between 80 to 100. Majority of the wall mounted suctions have pressures of 150, 200, which can tear the oral mucosa of the neonate. So that is the reason why when you use a wall mounted suction, you should set the suction pressure at 80 to 100. Whereas an oral mucus sucker will be very, very safe. You just cannot exert that kind of pressure and it's a disposable equipment. D-lease, for your information, is not recommended at all in NRP.
Yeah. Is it mandatory to keep the meconium sucker?
No.
And but we have 10 or 12 size suction catheter because I never used. And nowadays, even if it is obstruction only, we are using. Then why we are recommending meconium sucker, meconium remover? Why it is? Dr.
Okay.
Sahana and for all the others. Yeah, Chandrakala, please.
Yeah, right. So, as per the current recommendation, there is no need to keep the meconium aspirator. One. And also, as per the previous recommendations, so in case if it is non-meconium, it is 10 French, and if it is meconium, it is 12 French was recommended. But now, even though if it is meconium, stained amniotic fluid, only if there is secretions, we need to do the suctioning. Otherwise, even in meconium, there is no indication for doing suctioning.
Yeah.
Dinakar, that's not part of the NRP kit now at all. Meconium aspirator is not part of the NRP kit.
Right.
So next question.
So
Yeah,
excuse me, sir. This is Prashant, sir, from St. John's.
Prashant, you are there yet? Okay, please.
Just to,
Sorry.
yeah, just to add on to this, sir, the mucus the meconium aspirator. The only place where the NRP 7th edition mentions this is in the intubation chapter. So in one of the paragraphs, it says if after intubation we are anticipating a thick secretion in the trachea, the first option is to pass a suction catheter, do the suction. If the suction is not successful, and then there is a role of mucus extraction. That's the only place where he has is mentioned. And as ma'am rightly said, it's not a part of routine NRP kit like how we used to do religiously. But having said that, so since it's mentioned, it's good to keep it. I don't think we might have to use it because especially when we are intubating the baby and doing a suction, I don't think it will be required. But only thing is we need to know that it is still mentioned in that 7th edition in one of the paragraphs.
It is mentioned.
Overs.
It is.
Overs.
It is. Okay, next. We'll go slowly one by one. Is it correct? Is it correct? SpO2 should be connected after 30 seconds if it is baby is not good. If it is so, okay, we are also connecting. ECG should be connected if heart rate is less than 60, or is it after the chest compression? Because everything looks similar, because chest compression is when heart rate is less, and from the beginning if the heart rate is less than 60, because that what just now Dr. Prashant told, do first resuscitation for 30 seconds, then do the MR SOPA if it is first only if the chest rise is there, good, then later chest compression, intubation if it is necessary, chest compression, that time to connect. What is correct? SpO2 and ECG connector, just throw the light. Anybody can take the.
Dinakar, SpO2, there are very, very strict indications when you connect an SpO2 monitor. In a term baby, you do not connect SpO2 monitor except for two indications. One is when you start free flow oxygen or when you start positive pressure ventilation. In a preterm baby, you always connect an SpO2 monitor like we showed in the video. It should be connected as soon as the baby is in the polythene bag. Twin pregnancies and pregnancies where there has been a bad fetal heart rate, expected, anticipated resuscitation, you start SpO2 monitoring within the first 1 minute of life. Persistent bradycardia was your second question. Please remember, in a persistent bradycardia, it is always failure to ventilate. So please look at your ventilation first instead of putting on ECG leads. ECG leads you will put only when you go into the stage of chest compression medication. If you're having persistent brady, please look at your ventilation, look at your tube size, tube position, see whether you are inflating the lungs. That is the commonest reason why you will have a brady. ECG monitor is not going to help you. Your correct ventilation is what is going to help you.
Yeah. Okay, next question. Dr. Chandrakala or Dr. I think so it's for Chandrakala. Madam, excellent talk. You told about round and anatomically placed very good what is it, mask. But
Mask.
we have both. But which one is really best? We have both. We know we are covering chin, nose, all those part theory we know. But only quick answer, which one is best?
Yeah, you can choose whatever you have in your unit, but what is important is to choose the correct sized mask. You can use whatever you prefer to use it, but it is important to have a airtight seal between the mask and the face.
Yeah. Next question. It is for Dr. Janaki and everybody. In our NRP algorithm of 6th, 7th, if the baby is not crying, baby is bad and depressed, tell the mother, cut the umbilical cord, take it to the separate place. Why so? Even after knowing and listening to Dr. Sahana talk, how much delayed cord clamping will help? Why can't we do? Can we do resuscitation till the baby heart rate picks up and the baby breathes? SpO2 increases after the resuscitation near the introitus without cutting the cord, because it is more better, everybody knows. Then why to cut the cord and take the baby away? In all, even 7th resuscitation also there, in spite of telling DCC is good, why it is done for everybody?
See, Dinakar, when we have a flat baby or a depressed baby, number one, all the procedures that we need to do, we need to have what is called a sniffing a rose position. This mild extension of the neck can never be achieved when you hold the baby near the introitus. How can you hold the baby in a sniffing position? That is not possible. Second, you do not know how long your resuscitation will go on. So thermoregulation, even for a term asphyxiated baby, is very important. As I told you earlier, drop of even 1 degree temperature during resuscitation increases mortality by 28%. So by holding the baby near the introitus for 1 minute, a flat baby, you are not taking care of your temperature, you are not positioning the baby, you cannot ventilate the baby in that position. Sniffing a rose position and shoulder roll, all these are very, very important for you to get good ventilation. All these cannot be achieved by holding the baby near the introitus. The advantages of this blood transfer is far less compared to the hypoxic damage that this baby is going to have. The first golden minute you are losing by holding the baby there. The entire focus is on the first golden minute. Your job is to oxygenate the baby within the first golden minute. This whole purpose is lost by doing DCC. Precedence is always for oxygenating the brain, not for hematocrit.
Dr.
Okay.
Prashant, you want to add anything? Because we know that near the introitus, there is a bed. There is a bed. We can keep the baby. We can keep the baby. And we, Prashant, can you,
Yes, sir.
Prashant Gowda?
Sir.
Okay, Prashant
Yes,
Vayan,
sir.
it's for you. Yeah. Prashant Vayan, it is for you.
Yeah, yes, sir. Yes, ma'am. It's taking some time. Can you hear me, ma'am?
Yeah, we can.
So, as ma'am said, sir, there is no two ways about delaying the positive pressure ventilation. Having said that, I think the next step forward is to look at placental transfusion with resuscitation. We all know that a study, I think it's over. I don't know if it's still going on in ICH Chennai, where some Indian company has actually come with a trolley where which facilitates the resuscitation on a trolley with the cord being intact with the placenta. So that is the way forward. So having said that, so right now I think for any baby who would want to who desires resuscitation, the air so the breathing comes first. Having said that, so if you look at the 2020 guidelines, so they talk about early delayed clamping, early cord clamping, that is, they have defined it as less than 30 seconds. And they prefer to dry the baby and then take a call on clamping it, rather than removing the baby as soon as possible. Clamping it as soon as possible. I think probably the guidelines have to be refined in that sense, because we have seen that once the babies are born, at some time immediately the baby might not cry. So that's why even if we look at our basic NRP, they talk about initial steps on the mother's abdomen. I think that's the way forward. So wait for some time at least to see if the baby starts breath, and then take a call.
Yeah, I am sorry. Yeah, Prashant, Chris Preps. I know that whatever it is there in the NRP, we have to teach. That is correct, and we have to stick on to that. But however, there are lot of YouTube videos are there, even in abroad. They are following even the asphyxia near the introitus. There are so many things are resuscitation. If it is their option, they are giving also in the AHA. But it's a NRP, whatever written, it's our duty to tell. That's all our duty. Anyhow, we'll go to the next question. In TPs, NeoFuff, we know it is a beautiful equipment. Everybody knows it is very good. If you are having it, even still ambu bagging to be kept, just now we know that. But nobody is telling. We have listened from Dr. Chandrakala's talk. Sometimes baby might need up to 30, 35, 40 people. Baby might need for it if it is a stiff lung. If it is so, why we are, that is also exactly like a square wave, or we ask sinusoidal wave. But if it is a stiff lung, we do need a square wave. But when nobody is talking about the pressure in ventilator, how we are doing is, if it is less than PIP, less than 20, we are using 6 to 7 liter or 8 liter. So 20 to 25, we are using 8 liter. If it is more than 25, 10 liter. If it is 30, definitely 12 liter. In ventilator, when we use the bias flow, here also flow rate is there. But nobody is telling even in the NRP guidelines, the flow is just, they are telling 5 liter is enough. How it will achieve that much pressure? If it is giving that much pressure, do you think it is delivering that much volume? That is question number one. The question number two is, even in the preterm, even 20, the flow liter is 20, they kept in the video demonstration. So which one to follow, how to follow, please? It's for everybody, one by one you can answer.
Okay, I'll answer. I understood that, in TP's resuscitator, the maximum flow they have recommended is 5 to 10. It is not 5. And there is a maximum set pressure we can keep it in TP's resuscitator, that is 40. So by default, it will not go more than 40. So this is like a protective phenomena. So if the baby has requires so much of pressure, more than that, that means this is an indication that you need to look at, is there any other congenital anomaly? Are there any other problems in a baby? So
Dr.
this much I
Chandrakala,
can.
very, very, very clear. You can see the any resuscitator up to 20 liter it is there.
Okay, the flow
Okay.
is it?
Yeah. Even in some resuscitator, you go to the Fisher and Paykel, up to 25, 30 liter is there. Go to the GE, up to 30 or 20 liter is there. Okay. So which one to set? Okay. Next.
So if anybody knows, and I don't know, I'm
Yeah,
not
Dinakar,
sure.
can I just add a point?
Please, madam, for everybody, please.
See, Dinakar, when you're having large pressures, you're having pressures of 25 by 30, 25 by 5 in a TPs. If you keep a flow rate of 5, the pressure will not rise. Just try it out. Unless you increase the flow rate, your pressure can never go beyond 25, 30. Your flow rate of 5 is recommended only for free flow oxygen in NRP. There is no recommendation to keep flow rate on the TPs. Flow rate on the TPs depends on the pressures that you have set. If you have set very high pressures like 30 by 7 or 30 by 8, naturally your flow rate has to increase. Otherwise, you can never achieve those pressures. You can try it on the TPs. This 5 liters recommended is only on the flow meter to be connected for free flow oxygen or for CPAP. Even CPAP, if you're using higher pressures of 6 or 7, you have to go up on your flow rate. It is as simple as that.
Yeah. And one more, very nice. Please, you people are the stalwarts. You please recommend to the central. This is the thing, because even we, sorry to tell that, I have taken the GE, I have taken the Fisher and Paykel, I have taken the nice Neonatal. We have seen how much it is achieves. To tell you very frankly, from Mr. Muthu Krishna, who is and Wilson, it is not delivering more than 10 ml to 12 ml. Okay, even PIP it will show in the monitor. It is not achieving. That is the reason this question is being asked. Next, even it is a very nice question. It is for Dr. CTG uneven full. I think so. It is for Dr. Chandrakala. Even after 1 minute of effective PPV, he has written good chest rise. Heart rate remains to 80 to 90, but SpO2 is 65. We have not got whatever it is, but it is not reached 75 to 80 even after 5 minutes.
Yeah.
Okay. But CTG was uneventful in that case, but heart rate was more than 140 in neutro. So that is a term baby. What all the steps we should take in this scenario? Now the baby is 10. We have done the resuscitation for 10 minutes. He is written once again bracket effective PPV. In this case, there was no pneumothorax is ruled out. Pneumothorax is ruled out. Other problems are ruled out. But only heart rate is not rising. SpO2 is not rising.
Okay. So this the first question, Dr. Dinakar, you asked that Dr. Janaki has already mentioned that in the special consideration. This falls in the second scenario where there is chest rise. That means if there is chest rise, that means the problem with the upper airway and the lungs are ruled out, and baby continues to have low saturation. So that is an
And the heart
indication
rate
that
is 80. 80 to 90 cannot do chest compression, but SpO2 is 75, not going above. Pneumothorax is ruled out. Good chest rise is there.
Yeah. If the saturation is low, if the saturation is not improving, that is one of the situations you need to think of CCHT, the cyanotic congenital heart disease. But in a neonate, cyanotic congenital heart disease is not a common scenario that presents in the labor room. It is mainly we need to think of any other respiratory cause, or failure to ventilate is the main cause. But in this scenario, you said chest is raising well, that means it is effective ventilation. So I would think of CCHT as one of the cause.
No,
Think.
heart rate was absolutely normal. Antenatal, everything is normal. Anybody? But
Dinakar, why don't we just increase the FiO2?
The-
See, we have started resuscitating with room air.
Madam, he has written increase to 100% oxygen given for more than, now it is 10 minutes. Heart rate is 80 to 90. SpO2 is 75. Antenatally uneventful. All the things is ruled out. What should I do now? I am in the labor room.
You have to rule out a pneumothorax. See, your
Already
saturations are low. Your
It is ruled out. Pneumothorax is
bradycardic.
ruled out. So is there any arrhythmias? We need to think of any other congenital
Antenatally
diseases.
it is normal 140.
Easy on ventilation or hello, Kotres sir.
Bolo.
It is the candidate for ventilation.
Okay, I'll go to the next question.
Mechanical.
Okay, what is the indication? Okay, it is for Dr. Chandrakala. Preterm or late preterm baby delivered. What is the indication for observation care? Observation care, because I have done MR SOPA. First initial 30 minutes is I have done all the basic things. Now after 30 minutes to 1 minute, I have done the MR SOPA for the baby to, but still baby is having cyanosis and mild grunting is there. Is there any exact, if I'll refer to the NICU, parents are telling I don't have money. If I'll keep on the baby, sir, you should have referred that time only to the NICU. Is there any clear cut, anything is there? So this baby will go for this observation, will go for a observational care to the mother or NICU. Medical legal, I am stuck. Please, anybody can answer this.
Right. So that baby, you said that baby requires initial steps of resuscitation. Any baby requires positive pressure ventilation for more than 1 minute is an indication for sending him for observational care. Observational care is given bedside next to the mother, where we need to monitor the baby every 15 minutes for 1 hour. So this is regarding the observational care. What is the second question, Dr. Dinakar?
Chandrakala, it is very clear. 30 minutes he has done the initial
30
thing.
seconds.
30 seconds.
You meant 30 seconds, yeah.
Yeah, sorry. 30 seconds.
Yeah.
Okay. Later he has done another 1 minute, all the resuscitation. Now baby has come up, but still mild cyanosis grunting is there. Mild.
Yeah.
Okay. Now he is stuck whether, because now 1.5 minute is over. If it is 1 minute, then observational care. Now he is in dilemma of 1.5 minute. He has not done any chest compression or intubation. So whether to refer to the NICU or mother.
He can keep the baby next to the mother, where he should monitor the baby every 15 minutes for 1 hour. And many times it can be because of hypothermia. The baby may have mild cyanosis, but we need to monitor next to the mother. There is no need to shift this baby to NICU.
Okay. Now, very nice. Dr. Prashant YN. Dr. Prashant?
Yes, sir.
Dr. Prashant, this question is for you. Sir, you have showed in your PPT vocal cord guide line. Black thing, there were 2 lines I have seen in your presentation on the ETT. But I didn't understand. And you told there was one flower bracket also you have put on your presentation, vocal cord. Vocal cord guide, usually 1 line will be there. But that line should fix on, according to me, that line should fix on exactly on the vocal cord. So you showed the 2 lines. I didn't get you. Sir, can you please tell us?
Yes, sir. Actually, that was taken from NRP textbook, sir. That photograph is not Indian. So India, when we look at Ramson's cannula, so there's only one vocal cord guide. So the mark what I just showed, so we'll have only one guide, and some of the ET tubes also come with the tip which are black. So this is just to kind of guide it, and I don't think in India we have that 2 vocal cord guide in a ET tube.
Yes.
So that's
okay.
correct.
So people understood. That guide, that black mark should be the placement exactly on the white two lines
vocal
of
cord.
vocal cords.
Vocal
Is
cord,
it correct?
Right, sir.
So he got it. Okay.
In between.
Next.
In between.
Yeah. We'll go. Then because there are, for Janaki, there are so many questions. Are there? Glottic. Sir, you told, what is it? Epiglottis. We understood, you told it is a leafy thing. We understood what is epiglottis. We understood what is glottis also. You told below the vocal cord area is glottic. Then above the vocal cord area, epiglottic. In between the epiglottic and vocal cord, I can see there is lot of place, at least 3, 4, 5 millimeter. What is that area called, sir? I am very much curious to know. Prashant, YN.
The space above. I mean, I think you're testing my ENT knowledge, sir. Okay, so the space above the epiglottis is vallecula, and just below
We
between those
understood,
two
sir.
is
Epiglottis to the base of the tongue is vallecula.
supraglottic space, sir.
Yeah. Okay, no
I think
problem.
It's very
Prashant Gowda, please hold on, dear friend. Please. Chandrakala, when we should check heart rate? Because you were telling at chest compressions after, and even madam was, you were telling, sorry, Chandrakala, you told after 60 seconds of the chest compression, then only you check the heart rate. After that time, after how many seconds we should check the heart rate?
Okay, after giving chest compression, every minute we need to check, and every minute, every 60 seconds, we need to check, keep on checking. And if the heart rate is more than 60, we can stop chest compression. And when you go for positive pressure ventilation, at that point, we have to check every 30 seconds.
Positive pressure ventilation. See, when we first, Chandrakala, is it correct?
Chest compression, after chest compression, we need not have to, we should not interrupt chest compression in between for one whole minute. So we need to count the heart rate only after 60 seconds.
Then after that, in case if chest compression continues every 30 seconds.
No. Every 1 minute every 1 minute we will check.
Okay.
And still, if it is not better, we have to go for medication. The next step.
Yeah. No.
Sir,
only I am asking about
Kotresh,
heart
sir.
rate. I am not Kotresh. I am Dr. Dinkardia.
Dinkar, sir. Okay, sir. Whenever a child is on chest compressions, it is a mnemonic to be understood that you have to count the heart rate only after 1 minute. Once you have stopped chest compression, you are doing positive pressure ventilation. So it has to be remembered that positive pressure ventilation every 30 seconds. As long as in chest compression, it is 1 minute.
Okay, very nice. Thank you. Next, Dr. Prashant YN. Sir, in your presentation, you have told medication indications. You have told it's very good. Sir, after 60 seconds of the chest compression with the PPV, we should think of giving the medication of adrenaline. That everybody we are following. It's nice. At the same time, you put one small worm to our brain, telling after 30 seconds, if the heart rate is less than 60, you can give. So we didn't get it. What is that? Dr. Prashant YN.
Sorry for the confusion, sir. I think it's actually very clear, which Sri Salam sir said and even Chandrakala ma'am said. Maybe I told with the
No, your presentation PPT.
Yes, sir. So that probably I mentioned. So before we think of giving medications, we need to make sure that we have given 30 seconds of effective positive pressure ventilation and 60 seconds or 1 minute of positive pressure ventilation with chest compression with 100% FiO2. So I think the comment was made in that note, not for medication. So medications means to say for us to get there, we need to have 30 seconds plus 60 seconds. That should be clear. And,
So,
and with 100% effort. And if
yeah,
I mentioned it very ambiguously, sorry for that.
yeah, I think so. All the questions are over. Thank you very much for all the speakers. Okay, over to Dr. Prashant Gowda. Prashant,
Thank you, sir. Thank you.
no, no. If there are any other questions, please ask. Tell the delegates to ask,
Yeah.
because
So
whatever it is
thank
there, they have
you,
sent to
sir.
my WhatsApp. I am asking.
Yes, sir. Thank you was for you, sir, for asking questions from the audience side. So, if anybody now has any question related to our today's topic, they can unmute or they can raise the hands and they can ask our expert. All of them are there. You can unmute and you can ask the question.
Dr. Prashant, somebody was
Yeah.
asking why intubation can't be done through right hand, by right hand.
Right hand.
Right hand. So, because you'll be obstructing the view, that's what I was saying. You can't place the ET tube and you can't visualize. Somebody was asking in the question box.
Okay, I didn't see that question box, dear. Prashant.
Yes, sir. Exactly. I've actually
Whatever they
noted down
have
the
sent to
question.
me.
Yes, sir. I've noted down the questions.
Yes, sir. Yes, sir. He's answering.
Yes, sir. So I think Dr. Srisailaman has actually replied it just after that question. So the way the miller's blade is actually done, is that we have a bulb on the right side, sorry, the left side, so that the right side there is a gap over here. So if we are to intubate a baby with the right hand like this, so maybe we are obstructing the view because there is a light over here, we won't be able to see the vocal cord. So if you're using this miller's blade, which is standard, it's only left hand, and we should see from the right side. This is how we should go.
And one more observation was done, like before inserting for umbilical vein catheterization, before cutting it, I think you should put a tie at the level of the skin.
Yeah.
So I think that observation you should.
No. He has already. In his video and PPT, there was a tie. He showed it.
Yes, sir. There was a tie. Probably during demo, it was not put. As I mentioned, tie is definitely desirable. Sometimes we might not put it. And definitely, I agree that point. So during demo, I actually did not put it, but I did mention that tie has to be placed.
In the preparation, you are having the tie.
Yes. And the second observation which Asha ma'am had done is she was asking us what was the thing which I put. So we usually use chlorhexidine for our umbilical catheterizations in our unit. That's why it was looking green. I know that it is not standard, but in our unit we have taken a policy. But so other recommended thing which I did mention was to use betadine and spirit.
Yeah, Dr. Janaki, there is one question for you from Suheen. Role of surfactant preterm with severe RDS in non-immune hydrous fetalis.
In the delivery room, is it?
She has asked. Yes, madam. I don't know. Suhina. Role of surfactant in preterm with severe RDS with non-immune hydrous fetalis.
I think the precedence should always be to manage the hydrops, not surfactant. See, this baby is very hydropic. This baby probably has a pleural effusion, pericardial effusion, etc. So our first duty is to drain the pleural effusion, ventilate the baby. After you've achieved the stabilization, then perhaps you can go for surfactant. The first thing would always be to establish good ventilation by draining the pleural effusion. If it's a very preterm baby and your unit believes in prophylactic surfactant, well, go ahead. But not many people are doing prophylactic surfactant because all of us know that the NNT or the number needed to treat is very high. It's really not worth it for a country like ours. Precedence will always be towards treating the hydrops. Whether it is immune or non-immune is besides the point.
Last question by Sanjeev J at 8:40 he has asked, can we give adrenaline through peripheral cannula?
Yeah, certainly. If you're able to get an IV line in, it really doesn't matter. The only thing is it has to get into the circulation. In a shocked baby, if you can get an IV line in, hats off to you. You can definitely do it by peripheralitis.
But in a neonate, the easy way to get the IV line is through umbilical. It's
Absolutely
more easier.
agreed. Absolutely agreed. But then there are some miracle nurses who will get peripheral IV lines in. So there isn't much difference.
Yeah, I think so. All the questions, whatever it is there, I asked. Thank you. Please, Dr. Sahana Madam, Dr. Chandrakala, Dr. Prashant Vayan, and Dr. Janaki Madam. Very nice. Thanks for your time. I know that we have taken almost 5 hours. More than that, I know you people will take 8 hours. Sorry, I have cut down the 3 hours of your NRP and sitting in virtual. Thank you very much. Thank you. Over to Prashant Gowda.
Thank you, sir. Thank you, madam. I request our president, Kotreshi sir, to speak a few words about today's Herculean session. And there are a lot of interested audience, and I'm already getting extremely good feedback. Everybody has said hats off to our mentors, especially our 4 speakers for today. Janaki madam, Sahana madam, Chandrakala madam, and Prashant. Sir, Kotreshi sir, over to you, sir. Kindly unmute and speak, sir. Kindly unmute, sir. Kindly unmute, sir. We can't hear you, sir.
Kutresh sir.
Kotresh sir, we can't hear you. Kotresh sir, we can't hear you. We can't hear you, sir. You have to unmute yourself. We can't hear you. Sir, you have muted. Unmute yourself, sir. You are muted.
Prashant.
Yes, sir.
Just to tell everybody.
Can you hear now?
Yes, sir. Yes, sir. We can hear you.
Prashant and Dinkar. See, my activity, academic activity started from NRP itself. So I have grown up to the NNF president. I am very much proud to say in my tenure, all the stalwarts like Dr. Chandrakala, Dr. Janaki, and Dr. Sahadev very much have been Sahana also. I given a very good presentation. It is actually like a virtual presentation of workshop on the table on digitally. So they have been meticulously planned and well shown and well planned from the NNF board this time. And I am very much thankful for Prashant and Janakar have been a very good activities shown by NRP activities. Our main aim is to prevent newborn deaths now. So hats off to our stalwarts and speakers have given a very good presentation towards what can be done. A basic from newborn delivery to the drugs and as well as the newborn preterm care also. Wonderfully done. Very thankful for all the delegates and participants also.
Thank you, sir. If whoever is there, if they all come on video, we can take one snapshot and I'll put it in the group. We can share it. It's going to be an historic moment that we are trying something like this, very unique. Probably this is the beginning of new beginning. So I request all of you to come on the video. Kindly switch on the video. I'll take a screenshot of the video. Kindly switch on the video camera. Please switch on the video camera, all of you. Please switch on the video camera.
Dr. Prashant, your seating arrangement is excellent.
Thank you. I request all of you to come on camera, video camera. Kotreshi sir, you just, yeah, you're back. All of you, please
Hey,
switch on the
Prashant.
camera. I will
Prashant?
tell in 2, 3. Yes, sir.
No, Prashant. I want gold class. You are making me sit in the front. Gandhi class, I don't want.
No, let
Sure,
Dinkar and
definitely.
Prashant sit front.
Camera.
No, let Dinkar and Prashant sit in front.
Sir, Gandhi class, sir. 75 rupees.
No, not a Gandhi class.
Madam, Samira madam, bagunnara.
Switch on the
Samira
camera.
madam, bagunnara.
Camera. Delegate, kindly switch on the camera.
I am doing good. Dinakar, I am enjoying the moment.
Chaitali is also there.
Kindly switch on the camera. Kindly switch on the camera. Please switch on your camera, video camera. Okay, ready? Shall we go for a thing? I want everybody to smile because it's going to be an historic capture. Okay, with count of 3, I'll take a screenshot. 3, 2, 1. Say cheese. Thank you, one and all. Have a great Sunday.
Thank you.
Thank you,
Prashant.
madam. Thank you.
Thank you.
Thank
Thank
you.
you. Thank you.
Bye.
Thank you. Thank you all.
Thank you. Bye.
Thank you all.
Bye.
ma'am.
Bye.
Thank you.
Bye.
See you. Namaskar. We'll join once again.
Excellent.